So today I was going to talk to you about cancer in pets. I'm a veterinarian that's trained as an oncologist, so I treat cancer in pets, which it sounds like a very unpleasant thing, and certainly it is, but there's a lot that we have to learn about cancer in pets and a lot that our pet cancers can actually teach us about cancer in people. So if there has to be a silver lining that we certainly can learn from our pets to inform about human cancers and drug development and diagnostic development, that sort of thing. So there is some excitement in treatment of cancer in pets. And I think I have to click on the screen. Here we go. So just a little bit of background about me. I'm from Northwest Missouri. I'm from Maryville, Missouri is where I grew up. So I actually did my undergraduate work at Northwest Missouri State. And then I did my DVM at the University of Missouri. So 4 years of undergraduate and 4 years of my DVM degree. And then I did an internship, a one-year internship after I graduated from veterinary school up in upstate New York in Rochester, New York. I learned all about lake effect snow in Rochester, New York. So that was an exciting year. And then I came back to Missouri. I did my residency in oncology at the University of Missouri. So most of my training was done in the state of Missouri. But then after I finished my residency, I actually practiced in Kansas City at Mission MedVet, which is now VCA Mission, I believe. I practiced oncology there. And then after about a year and a half there, I actually went back into academia and I started teaching at Auburn University. So I was in Auburn, Alabama for 3 years. And then I moved back to the Midwest and I've been in Kansas at K-State now for almost 10 years in July. So moved back to close to family. So in case anyone is wondering what oncology means as an oncologist, oncology is actually the study of cancer. And studying cancer, it's not just treating pets with cancer, but studying both the causes, the development of cancer, how do we diagnose cancer, and then ultimately, how do we treat cancer? Because that's what, as a clinician, that's what we want to do, is we want to help our patients as much as we can. But something else I mentioned earlier is the One Health initiative, in that we do know that dogs and cats have similar genetic makeup to people. It just happens to be that their genes are on different chromosomes, so oftentimes they're split up in different locations. But many times the same genetic drivers for cancers in people are the genetic drivers for those cancers in dogs and cats. So we can learn a lot about the development of cancer and the treatment of cancer from our pet population. And one of the really important things is the development, in the sense that what are potential causes of cancer, and are there things that we can do to decrease the risk of cancer? Because most cancers are not inherited genetic diseases. They're actually changes in the DNA that have happened over time. And that patient, I'll say patient from a dog, cat, person perspective, changes in the DNA that have happened throughout their lifetime. Some cancers are genetic and inherited. Those genetic mutations are inherited, but not very many. So when we think about practicing oncology, one of the first questions that I'm always asked is, how in the world could you treat cancer in pets? That seems like such a depressing thing to do. And while it is, it's also very uplifting, because we have the opportunity to help the pets, to help these members of the family try to feel better, live better for as long as possible. Now we're learning that cancer can be more of a chronic disease and not such a acute, life-ending disease, potentially. So there are a lot of things we can do to extend the life of pets, good quality of life. And we know now that owners are dedicated to their pets, and pets are part of the family. And these are some of my favorite statistics to talk about, is the strength of the human-animal bond. I probably don't have to tell any of you guys here that are here listening to veterinary talks in your free time, but there have been some surveys that have done of pet owners, and 63% these statistics are not new. This was about 10 to 12 years ago, but about 2/3 of Americans own a pet. And more people have pets than children in this day and age, believe it or not. There's a lot of empty nesters that get pets after their children leave the house, and so pets become our children. And 70% of pet owners think of their pets as their children. I know I refer to my pets as my children. I'm their mom. My husband's their dad. So their siblings are my children, which my pets may prefer that not to be. But many of us celebrate our pets' birthdays. We include our pets in our holiday cards. We give them birthday gifts. We say, I love you to our pet at least once a day, if not more. It's a picture of an elderly woman and her knight in shining armor. This is actually a picture of my daughter here on top of our chocolate lab. They are best buddies still today. So, the majority of pet owners, 80% of us, acquired our pets for companionship. So they're not just working animals, but they're actually, we have them because they are companions. And this is my favorite statistic, that 57% of owners surveyed say if they were on a deserted island, they would choose their pet to be their only companion if they were stranded there. So there is no doubt that that human-animal bond is really strong with their pets. So our pets are really important, a really important part of our family, important to our hearts and our well-being. And so being able to help them as much as we can, and like I said earlier, make them live as long of a life and as good of a life as possible, because quality of life is ultimately what's most important. We want our pets to have as good a quality of life for absolutely as long as we can. So unfortunately, cancer does happen, and it's increasing in incidence in our pet population. It is the #1 cause of death in dogs greater than 2 years of age now. And about 25% of dogs will die because of cancer. So it is something that happens frequently. And as veterinarians, even general practitioners, it's something that is diagnosed and that we work with and deal with on a daily basis. So it is, unfortunately, the leading cause of disease-related death in dogs, almost 50% of them, and about 1/3 of cats. So it happens. And as we learn more and as veterinary medicine progresses more and more, our pets are living longer and longer, which is probably one of the reasons we're seeing more cancer, because our pets aren't dying at an early age for other reasons. They're living to be geriatric animals when cancer is more likely to develop, when those genetic mutations can pile up and a cancer cell can develop. So when I think about what are potential symptoms, what are things we can look for that may be signs of cancer in our pet population, there's not a definitive problem. There's not one thing you can see or find that says my pet has cancer. But certainly warning signs lists have been generated to help us understand when might there be a problem that I need to have my pet evaluated by my veterinarian to see if there could be something abnormal that potentially could be a cancer. That's not to say that a lump or bump is always going to be a cancer. Certainly we can have abscesses and other problems, but lumps or bumps that continue to grow are a concern. Wounds that don't heal. Here's a picture of a cat with a squamous cell carcinoma on its nose. Squamous cell carcinomas in cat's skin is similar to squamous cell carcinoma in people's skin, and it's a UV-induced cancer. So sunlight exposure to that non-pigmented skin over time has caused for genetic changes that allow that cancer to develop. And it looks like a scab on the nose, and oftentimes there is a scab on it, but that scab continues to grow and grow instead of getting smaller and smaller. Certainly if we catch them really early, we can cure that cancer if we catch it early and treat it early. So lamenesses that persist or are recurrent, unexplained weight loss is a concern. There are other reasons for unexplained weight loss. Sometimes it might be as simple as parasitism. Animals that are infected with parasites can certainly have weight loss. So, inappetence is another concern. Difficulty eating or swallowing. It could be as simple as a dental problem, but it could be something more of a concern. We had a patient in today with a large mass associated with his mandible, that was his presenting complaint, was trouble chewing his food. Bleeding from any sort of body opening, whether it be the mouth, the nose, the anus, so the rectum. Offensive odors, particularly from the mouth. Sometimes it's, like I said, it's dental disease, but sometimes it's something more significant. Difficulty breathing or difficulty going to the bathroom are symptoms of the problem, signs of the problem. And lethargy, loss of stamina, can be something of concern. So anything on this list should make you think about having your pet evaluated for cancer. And these are certainly things that we have listed in our waiting room for owners to let us know if they have concerns with their pet. This is a picture of a dog here. Actually, he's got what we call epistaxis. He's got blood coming from his nostril. You see around me. From his left nostril here, it's a little bit purulent, so has a little bit of discharge with it too. But he actually has a nasal tumor inside his nose. And you can also see how his third eyelid is lifted up over his eye. His eye is actually a little bit deviated. It's pushed out of the socket because there's a mass growing behind his nose. But it's causing blood to come out of that nostril. And this is a picture of a kitty with lymphoma in his GI tract. This kitty, we started treatment for lymphoma, and the cat did really well for several years. But he's a cat that lost weight and was unkept. He looked particularly horrible there because he just had a bath. So he was also a wet cat, but he had some fairly chronically progressive weight loss. So what causes cancer? I mentioned earlier that cancer is a genetic disease. So we have DNA mutations that pile up on top of each other. Multiple mutations need to happen before a cell becomes a neoplastic or a cancerous cell. We usually think that there's a minimum of 5 to 6 genetic mutations that have to happen, or DNA mutations that have to happen in a cell before it can survive and become a neoplastic cell. We have genetic mutations happening in our body all the time as our cells develop, but there are checkpoints in our cell cycle, in the cell cycle of our cells, that cause those cells, if they're abnormal, if the DNA is abnormal, those cells are told to die. They're not allowed to continue through the cell cycle and go on to divide. But as multiple mutations develop over time, it allows them to avoid those checkpoints, and then they can eventually survive. There are a lot of different things that can cause genetic mutations. The number one thing is probably bad luck. But also there are viral factors, so viruses. Epstein-Barr virus is a human virus. We think about it with mononucleosis. That is a virus that can be associated with cancer development. There's feline leukemia virus in our cat population, bovine leukemia virus in our cow population. So there are a lot of different viruses that can be associated with cancer development. HIV and FIV are also viruses that can be associated with cancer development. There are chemical factors. Smoking, tobacco smoke, is a chemical factor associated with it. Also, when we think about the chemicals that we put on our lawn, 2,4-D is a carcinogenic compound. There are physical factors like the sun. We know sun exposure is a risk factor for the development of melanoma in people, for squamous cell carcinomas in people. I showed you the picture of the cat with the scab on his nose. So even in our pets. And then there's hormonal factors. So we know that dogs and cats that are spayed, so if they remove their female organs before they're a year of age or before they go into heat for the first time, we can almost completely prevent the risk of development of breast cancer or mammary tumors in dogs and cats if we spay them, because we've prevented all of that mammary tissue from being exposed to hormones, which stimulate growth and development. So there are a lot of different factors that can be involved in causing genetic mutations or risk factors for development of cancer. So how do we diagnose cancer in our pets? One of the first things we do if we have a pet that presents to us with a lump or bump, we'll aspirate it. This is a picture of us doing an aspirate of a lymph node underneath the jaw in a dog. So we'll use a needle like we used to give a vaccine. We'll use that needle to go in and try and suck out some of the cells, if you will, and then we'll squirt it on a slide and stain that slide and look at them underneath the microscope. And here's a picture of a dog that actually had lymphoma. This cytology preparation is tumor cells that are lymphocytes. So this is a picture of a dog with enlarged mandibular lymph nodes. You can see them. It looks like she's getting ready for winter and has tucked away lots of acorns, but in fact she hasn't. Those are her mandibular lymph nodes. And so we aspirate those lymph nodes and look at them underneath the microscope and see a population of immature lymphocytes. So these big cells are lymphoblasts, and these are the tumor cells in her lymph node. There's other cells inside of here. There's red blood cells. These little pinkish orange cells are red blood cells. This is a picture of a neutrophil, or this cell is a neutrophil. And there's fat, all these little kind of clear vacuoles in the background. There's some fat mixed with this aspirate. So we also can do biopsies. Should this aspirate not be conclusive, we can do a biopsy, so we can go in and actually take a chunk of that lymph node out and submit it to the pathologist so they can fix that tissue and, again, look at it underneath the microscope and evaluate it for us. We oftentimes take radiographs or ultrasounds to look inside the chest cavity or the abdominal cavity. And we can do more advanced imaging like CT scans and MRI scans also. Can you imagine what the problem with doing a CT scan, or the challenge of doing a CT scan, is in a dog?
Getting them to stop moving.
Exactly, getting them to stop moving. Because if they're laying on that table and they're moving, we're not going to get a very clear picture. We're going to have one big blur, so it's not going to tell us very much. So unfortunately, our pets have to be anesthetized for us to do a CAT scan, because if they move, they don't learn much. So same thing goes for an MR, which makes the cost of those imaging procedures much more expensive just because of the anesthesia. So how do we treat cancer? Very similar to how cancer is treated in people. Surgery is one of the first things we think about. If we can remove it, we want to do that for most cancers. Chemotherapy is something we use, particularly for cancers that might be systemic, might be throughout the body. Lymphoma is a good example of that. Lymphoma is not very often confined to just one location in the body. And so if we think about treating that disease with chemotherapy, not only because it's multicentric typically, but also because lymphocytes are exquisitely sensitive to chemotherapy the majority of the time, at least initially. And so since lymphoma is very responsive to chemotherapy, we usually think of that as our first-line therapy for multicentric lymphoma, so for the majority of lymphomas that we treat in dogs and cats. Unfortunately, it's just not possible to go around and remove every single lymph node. If we could, we would, but it's not possible. Radiation therapy is also a frequent therapeutic choice. We use the same kind of radiation therapy that they use to treat people. As a matter of fact, the machine in our hospital is refurbished from a human facility. So more and more tertiary veterinary institutions are getting brand new equipment. So there are a lot of institutions, a lot of my colleagues have state-of-the-art radiation equipment, so it's pretty impressive what we're able to do in treating our pets. You can imagine what the cost of that might be. Again, pets have to be anesthetized, because if they're not anesthetized, we don't treat the right spot. So, and then we also use the immune system to help us treat cancers. So we try to specifically stimulate the pet's immune system to recognize that that cancer cell is abnormal and go after it and attack those cells itself. So the immune system can be our worst enemy when it comes to treating cancer, because it's not helping us get rid of it. It's allowing those cells to survive. So there's a lot of therapies now that are actually specifically targeting the immune system to sensitize it to the tumor cell and have the host help us kill those cells. To be quite honest with you, a combination of all four of these therapies, we call it multimodal therapy, is ultimately what's probably going to be necessary for our longest term control of cancers. So here's a picture of a dog that has a chondrosarcoma, or I should say had a chondrosarcoma. And when you look at his x-rays, you can see his ribs coming across. Here are all these white lines coming across are his ribs. But you notice, it's not as easy to see as projected, but when you look at this rib right over here, you lose that rib as it's going around, as it's curving around his thorax. So right here, there's kind of loss of that rib, which coincides with this bump on his lateral thorax. This dog's laying on his right side. And if you're squeamish, the next pictures are actually this dog in surgery, because this dog was taken to surgery to have his rib resected. And surgeons always like to leave lots of blood around, but this is a picture of the incision that they made to remove that rib. And when we think about, we'll go back to this previous picture, when we think about removing a tumor associated with the rib, we tend to think about removing a rib behind it and a rib in front of it so we can have complete resection of that tumor, because we don't want to leave any tumor cells behind if we can avoid it. And so this dog had 3 to 4, I do believe, actually ribs removed. 1, 2, 3, 4 were taken out in that surgery because of the extension. This tumor was actually involving 2 ribs. But you can see when they closed him up, they actually put a piece of mesh in there, because one of the questions might be, what do you do with that hole? The heart is right underneath those ribs, and the ribs are protecting the heart and the lungs. So they put some mesh in there to really kind of strengthen that body wall. And then we closed him up, and here's the resected tissue. And this tumor was a chondrosarcoma, and dogs with chondrosarcomas can do really quite well. This dog actually lived for 3 years after the surgery and died from something completely unrelated to his tumor. So not all the time do we have that kind of outcome, but this was about a 10-year-old dog when it was diagnosed. So, and a large breed dog, that's a fairly 13 years old, is a fairly reasonable life expectancy. Mm-hmm. So then thinking about chemotherapy, I mentioned lymphoma earlier. So it might be the primary treatment of the cancer, but it might also be used to try and control metastasis. If we know that we have a tumor that's biologically aggressive and likely to spread to other locations, we might recommend chemotherapy to try and slow down or prevent the development of metastatic disease. Osteosarcoma, or a primary bone tumor, is something that we use chemotherapy for almost. We recommend it because we know that there's a high risk for tumor spread in those patients. These are pictures of us actually administering chemotherapy. And I have this picture up here of the EquiShield chemotherapy dispensing and administration device, because when we think about chemotherapy drugs, these cells are actually killing cells. And so the drugs that we use themselves also have a risk of toxicity to the people administering them, especially when we think about long-term exposure to the chemotherapy drugs. We're giving them every day. And so these devices are called closed system drug transfer devices that are actually used to try and minimize the risk of exposure into the environment so we can keep our staff safe while they're administering the drug, and also prevent getting any medication on the outside of the patient. We want to keep the patient clean as well, because our patients are going home and going into their owner's environment. So we want to do what we can to limit the contamination of the environment with these medications. When we think about chemotherapy, one of the first questions I always get are, what about the side effects? And one of the first questions many owners ask is, my pet going to lose their hair? Because that's one of the main things, common things that happens in people. The good news about dogs and cats is they don't have continually growing coats for the most part. There are some patients, you can see this little boy here, his name was Luther. He was a Bichon, believe it or not, and he lost a fair amount of his hair. One of our technicians actually made him a toupee one day when he was in for chemotherapy. So everybody has to have a sense of humor, right? But Luther, this is a picture of a strong human-animal bond. Luther was their child, and Luther actually had more clothes than I do. He came into the clinic every single day. Every time he came in, we saw him on a weekly basis, he came in with a different outfit on. I don't think we ever saw him in the same outfit twice. Wow. So yeah, this is when I lived in Alabama, so maybe the people in Kansas are like, hey, be quite the same. But we do worry about the side effects from losing hair. Cats tend to lose whiskers. This kitty's name was Samba, and he did lose his whiskers, but he didn't lose any of the rest of his hair. And so that's usually the case with hair loss in our pets, is we can see some whisker loss. And in the breeds that have to go to the groomer all the time, we can see more hair loss, like Luther. But the majority of our dogs, they don't lose their hair. The majority of our cats don't lose their hair during chemotherapy. It might thin a little bit. Those undercoats might thin out a little bit, but they don't go completely bald, the majority of them. But Bichons and Poodles, we can see some hair loss. We can see suppression of the immune system by lowering of the white blood cells, because the blood cells are constantly dividing cells, and that's the target of chemotherapy, are rapidly dividing cells. And so it's a non-specific target, if you will, but we can see suppression of the immune system by lowering of the white blood cells. So we monitor the white blood cell count in our patients. We can, with some drugs, we can see an upset stomach, either with decreased appetite, you can see diarrhea, sometimes we can see vomiting. It only happens in about 20% of patients, and less than 5% of patients actually need to be hospitalized because of chemotherapy side effects. So the side effects are usually self-limiting and usually quite manageable at home. We'll oftentimes send owners home with anti-diarrheal medications and anti-nausea medications to have on hand in case their pet develops side effects like that. But most of the time, only about 20% of patients actually need medications. So. And then radiation therapy is another therapy that we use. This is a picture of our linear accelerator. And we use it to treat many tumor types. This is a picture of a kitty who had radiation therapy for nasal lymphoma. And this picture was taken about 3 years after she finished her radiation treatment. So these cats can do really well. You can tell with her little badge of honor exactly where her radiation field was with her gray hair. But we'll also use it sometimes to help with pain. I said our goal is to make our pets live as long as they can, as good as they can. And radiation therapy can help slow the growth and can sometimes affect the nerve cells, and it can also affect the bone destruction. So we'll use it in a palliative setting to try and help decrease pain. And this is an example of a dog with the osteosarcoma that we were using radiation therapy to try and improve his comfort with his tumor. So I have 4 or 5 cases that I kind of put together, summarized. Thought that might be as interesting as anything to show you patients that we treated. And this is one of my most favorite patients of all time. She was actually from the Kansas City area, just right around here actually. And her name was Gracie. She was almost 7 years old when we met her, and she's a beautiful chocolate lab. And she came to us because she had a mass in her neck. And she'd recently lost her ability to bark. So basically she lost her voice. And as we felt her neck, she had a palpable mass in her neck. This isn't actually Gracie, but a picture of a dog similar to Gracie with a mass in the same region. And as it turns out, her mass was right in the location of the thyroid gland. Thyroid gland, there's 2 of them. They lie on either side of the trachea, right in the neck region. And she turned out to actually have a thyroid carcinoma. This is an aspirate of a thyroid carcinoma. So just like I showed you earlier, we took a needle and we sucked out some of those cells from her mass, and we put them on a slide and looked at them underneath the microscope. And this is what her tumor looked like. It's a very, what we call a neuroendocrine appearance, where we see the, you can see the cells, but it's very challenging in some areas to see the cell border. You can see that there's a bunch of cytoplasm in there, but you can't see the cell borders nicely. And some of them you can, just so you can make out pretty nicely in here. But down here, you kind of lose those cell borders. And we call that a sea of, or naked nuclei in a sea of cytoplasm, which is a very neuroendocrine, typical neuroendocrine appearance. And the other thing we noticed in Gracie's tumor is you see these dark purple little spots in there. Those are actually what are tyrosine granules, and that's where the thyroid hormone is produced in those tyrosine granules. At least that's the presumption of what those purple dots are. And so we know in dogs that thyroid carcinomas are malignant, meaning they can spread to other locations. So before we made any treatment recommendations for Gracie, ideally for thyroid carcinomas, we'd go in and remove it. But before we made any recommendations, we wanted to see if there was evidence of tumor spread or tumor location elsewhere, because if there was, then what's in her neck isn't our only concern. We need to think about the entire patient when we develop that treatment plan. And so we took radiographs of her lungs, and we also performed a CT scan of her neck to look at the extent of the tumor to see if by chance it was a removable tumor. And so here's a picture of Gracie's radiographs. So this is of Gracie lying on, I believe this is the right side of her, on her right side. So we're really looking at the left lung lobes, if you will. But when we look at x-rays, here's her spine, right here up top. And all these white lines coming down, these are her ribs, those white stripes. This is her sternum on the bottom, and her diaphragm comes along here, so everything back here is in her abdomen. This is actually her stomach. You can see the breakfast she ate that morning in her stomach. And this is her front leg here. Here's her heart. And then these are her lung fields throughout here. And one thing we notice when we're trying to look for tumor spread, we're looking for abnormal opacities in the lung field. And when we look at Gracie, we see there's a little spot here, and there's a little spot up here. When we look at her on her other side, you can see another little spot here and here. Here's a spot up here. It may be similar spots that were on the other side. This one might be the same as what's on the other side. Because one thing we do when we're looking for metastatic disease in the thorax, we actually look to see if we can see it on multiple views. So we're taking more of a three-dimensional evaluation of the chest rather than just a one-dimensional evaluation. And so we were really concerned that these little nodules that we're seeing in Gracie's lungs were actually tumor progression to her lungs. Unfortunately, the only way to know for sure is to get some cells out of there. And these little nodules are really small. They're less than a centimeter in diameter. And so there's no way we're going to be able to reliably stick a needle in them, if you will. And going to surgery, if it is tumor spread, seems like a rather invasive thing to do from a diagnostic perspective for our pets. In people, they might actually consider that, going in and taking a biopsy to try and confirm that. And one more picture of her laying on her back, and you can see some of those nodules stick out for us. So unfortunately, we were concerned that Gracie had tumor spread to her lungs. But we went ahead, since those nodules were so small, we did go ahead and scan her neck to see if there was a chance for her tumor to be removed. And this is one image. I took a still image of her tumor. So this is actually the dorsal spinous process of one of her vertebrae. This is her neck muscle up here, kind of on her back. So this is her back, and this is the underside of her neck. Here's her trachea right here, and this really round thing is the endotracheal tube. She was under general anesthesia for the CT scan. So that's the tube taking oxygen and anesthetic gas into her lungs. And when we look at a CT scan, we're looking for asymmetry on the scan from the right side to the left side. And we're also, in this instance, we're looking for contrast uptake. These are her jugular veins, and you can see how those are bright white. So you can see this area right here, all of that is actually tumor tissue, and it's kind of engulfing her trachea. It's on both sides of her trachea. And I'll show you, this is kind of a video clip of the CT scan. We're starting farther up towards her snout. This is actually her brain right up here. So this is her skull. These are the inside of her ears. So we're actually at her ear level, and we're going to go backwards towards her tail. We're not going to go all the way towards her tail, but we're going to go back that direction. So I can play this a couple of times. But it shows you kind of how extensive her tumor is, and it goes fast enough. I don't think I can slow it down. Right in here, how extensive that mass is. So because it extended around her trachea, it wasn't a resectable tumor. So we had to think about something else we could do to treat her because she felt well otherwise and her owner was interested in treating her. So we thought about radiation therapy and we thought about chemotherapy because surgery wasn't really an option. And we had, as it turned out at this point in time, a new medication that was available to us that had just come out on the market called Olathe. And Olathe is a tyrosine kinase inhibitor. It's a small molecule inhibitor, belongs to a class of drugs called small molecule inhibitors. And it inhibits receptors on the surfaces of cells. And those receptors actually ultimately lead to signaling to the nucleus to tell those cells to divide. And so because Olathe was available and there was a discount on it at that time, and we had some evidence that it might be helpful in thyroid carcinomas, that's what Gracie's owner elected to do. And so here's a picture of Gracie's chest x-rays about a year later. And you can see that there are still a couple nodules. There's one that stands out to me here. In her lungs, here's one, and here's that one up here. They're a little bit brighter white, but they're really not a whole lot larger than they were before. And Gracie does not know those nodules are there. We actually did re-CT her neck, and unfortunately her mass didn't shrink considerably, but it shrank enough that she started barking again and really was back to her normal quality of life and doing everything normally again. So her laying on her back. And Gracie ultimately lived about 3.5 years with this tumor that without the Olathe treatment, without any treatment at all, we would have expected her tumor, her life expectancy to be less than a year long. Probably less than 6 months, to be quite honest, with the evidence of tumor spread to her lungs already. Now, you could ask, how do you know that it was tumor spread if you didn't actually go get a piece of that tissue? And we don't have that information, but chances of it being anything else are actually pretty slim. They did eventually grow a little bit, but never to the point where Gracie was symptomatic from those tumors. Unfortunately, Gracie's tumor did eventually start to grow again. And she had a tragic event associated with the stick and the trachea in her neck. But she did really well with a great quality of life for about 3.5 years. So she came to us at about 7, and she lived to be almost 11. So this next case is a kitty cat, a Bengal cat, named Cleo. And Cleo was a young cat, only 4. And she had an injection site sarcoma on her flank. I have a picture of it here. You can see she came to us already having had surgery, but that's where her tumor had been removed and there was a little bump, so there was recurrent tumor at the site of the surgery when she came to us. Have you guys ever heard of injection site sarcomas in cats? So cats can develop tumors at the site of any sort of injection, but most often it's at vaccine injection sites. And so they used to be called vaccine-associated sarcomas, but we now know that it can happen with other injection types. And so we call them injection site sarcomas. But anytime you have a cat that has a mass in the area where he had a vaccine, they can be benign masses. They can be granulomas that are inflammation associated with the injection, but they can also turn into a tumor potentially. And it can happen anywhere from months after the injection to years later. So watching our pets in the area, our cats especially in the areas where they've been vaccinated, if you feel a lump in that spot, it's something that should be checked out. And Cleo's tumor, her injection site sarcoma, was probably associated with the rabies vaccine. And I say that because that's where the right hind limb is where it's recommended to give the rabies vaccine now. It's recommended to give these vaccines as far distal or as far out on the limb as we can, because if we can resect these tumors, we can cure many of them. But unfortunately, they're fairly aggressive and invasive, and so surgical resection is not always possible because the tumor sends out finger-like projections into the underlying tissues. So we try to vaccinate them as far distal on their limbs, so if we can do an amputation to try and remove that limb and remove all of the tumor. But unfortunately, when it's up over the flank, or this region right here, it's up over the pelvis, and you can't remove the pelvis. You can remove part of it, but not all of it. So, so she had had surgery and had evidence of recurrence when we saw her, but her plan, the reason she came to us, was for us to do radiation therapy on her. This is a picture of our CT scanner. So she has a CT scan first. We do that to plan the radiation therapy. Again, this is the area where her tumor had been removed. And this is her CT scan. The one on your left is the one that's going to move now, the video clip. Maybe.
Way to the left. So. Yeah, there you go. Got it.
Can you see it?
Yeah.
Oh, okay. Here you go. Okay. So this one I think goes a little bit slower, but if you watch this area right up here in her flank, see that spot that comes in, and there, that region right there? You see that area of contrast enhancement? And that's the area of tumor for Cleo. I don't know why I keep losing it.
It's an extended.
Yeah, there you go. Show it one more time. Right in here. And you can see how it extends into that tissue beneath it. And this is just a still image of it, showing it right there on that flank area. We're actually looking down on her. We reformatted the CT scan, so she's lengthwise. This is her colon. That's full of poop right there. But this is her right flank, and you can see that area. All of that area is neoplastic tissue. So Cleo had radiation therapy. This is her CT setup. She has a beautiful kidney. And this is a radiation plan, which actually shows, this is the CT image here in the planning software. This is her pelvis. These are her femur, if you will. This is her colon. And so when we plan radiation therapy, we'd love to just be able to treat the tumor. But unfortunately, we have all that tissue around it that the radiation therapy is, the radiation is going to be deposited in. So the software actually goes through and tells us what the dose distribution for each one of these lines tells us how much radiation therapy is going to be absorbed into that tissue. So we can see how much the colon gets. We can see how much the pelvis gets. We can see how much the urethra gets. All those important tissues that could have long-term complications because of the radiation therapy. So this is her plan, and we want the majority of the dose to go to this site. But this actually over here, it's really small font, but it tells us how much radiation is being deposited in each one, at each one of those lines. So very helpful in trying to understand, predict what side effects might happen. So here's Cleo again. Here she is after radiation therapy, and you can see she has lost some hair because all of that area was treated because we wanted to make sure we treated the entire extent of her tumor. So Cleo also had chemotherapy afterwards because we know about 40% of cats with injection site sarcomas can develop tumor spreads. Yeah, so since she'd been through all that radiation therapy, we did want to try and prevent metastatic disease. We used a drug called doxorubicin. It's a human drug we use off-label in our pets. But last time we heard from her, she was doing really, really well without evidence of tumor recurrence or progression. Her hair did eventually regrow, like the kitty with the nasal radiation. It came back in gray. So she's not quite as pretty of a Bengal cat, but she has a little badge on her there. So she was doing very well post-radiation therapy also. Do we have time for another case? Sure. So this is a picture of, this is a patient named Sam. And Sam came to us because we had a clinical trial going on looking at an innovative therapy, actually looking at a bacterial toxin to see if that combined with radiation therapy would be more effective in killing cells with radiation therapy. Because radiation uses oxygen to damage cells to cause cell death. So radiation actually causes oxygen-free radical damage. to kill cells, to kill tumor cells. And if cells don't have a good oxygen supply, they're not going to die with the radiation therapy. And so many tumors, as they grow and grow and grow, they outgrow their blood supply. And so the center of tumors and pockets of tumors are what we call hypoxic, or have a very low oxygen supply. And so are poorly oxygenated. So that's why a lot of cells can survive radiation therapy, because they're not well enough oxygenated to die with the radiation therapy. And so the goal of this trial we were doing was actually to kill the hypoxic cells with the bacterial toxin and then use the radiation therapy to kill the well oxygenated cells. And it worked really quite well. This is a picture of Sam, who came to us from Texas. Cleo came from us from Oklahoma. Sam came from Texas. And this was his tumor. He had an osteosarcoma, so a bone tumor that was affecting his entire mandible or lower jaw there on the right side. You can see it underneath his tongue, all the way, that bump. All of this is abnormal tissue. And he would eventually, he would start to bleed and would be really painful in his mouth and wouldn't be able to eat because that portion of his bone was so abnormal. I've got Sam's CT scan, but you can see here's his left mandible on the bottom, and here's his right mandible on the top. He's laying on his side. And this is his mouth here, inside his mouth. Here's his endotracheal tube. But you can see how this portion of his mandible is really abnormal compared to the left side. You can see how there's a hole in it, if you will. I'm looking at his CT scan. Look at this area here. This is his tongue. You can see all of this is abnormal. And it extends almost in his entire length of his bottom jaw on that right side. So he had a really extensive tumor there that wasn't resectable because of how far caudally it was located. And it's an osteosarcoma. They do have a pretty aggressive clinical course. They can do better in the mandible than in other bones. But his owner came to us for this clinical trial. We deemed it not surgically resectable, so we did radiation therapy with the novel bacterial toxin. And this is Sam after 1 week of therapy. There is some edema in this tissue. It still looks pretty angry back here. But this is Sam about 3 months after he finished radiation therapy. And if you didn't know that he had a tumor there, you wouldn't be able to guess it looking in his mouth. About 3 months later, he came back for another evaluation, his final study evaluation. So this is about 6 months after completing the radiation therapy. And his owner said he just hadn't been quite as active as normal. He was eating well, but he just wasn't as active as normal. And he vocalizes when you lift him up. It's like his back hurts when you lift him up. And so we went ahead, we were planning to take chest x-rays on him. And we went ahead and did the chest x-rays. And remember that first surgery picture I showed you where there was a portion of a rib missing? When we look at his ribs, all of these on his right side appear to be intact. But when we start to look at them on his left side, you see this area right here. Can you see how part of that rib, there's kind of a hole there? Unfortunately, there was a mass there, and we aspirated that mass. We sucked out some of the cells, and there were cells there that were consistent with an osteosarcoma. So unfortunately, Sam had metastasis to the bone to his rib, in spite of the fact that his primary tumor was well controlled at that point in time. He still didn't have evidence of tumor recurrence at that point in time. But his tumor did go ahead and spread. He hadn't had chemotherapy. His owner elected not to do chemotherapy after the radiation. But he did get some chemo from his vet in Texas after this. I'm not sure how long he survived, to be honest. But just an example that it's not just the primary tumor that we have to worry about. So this patient, I think this is the last one I have in here. This is a patient named McGuire. And McGuire was another Kansas dog. He was a huge 170-pound Irish wolfhound that he presented for a recent history of lameness, forelimb lameness. And his veterinarian had taken x-rays, and he was worried that there was a problem in this portion of his bone. So when you look at this is the distal radius, so the bottom part of his arm, and it's the weight-bearing bone in his arm. And when you look at the upper part, you can see how smooth the inside of the bone is and how smooth the cortex, the bright white portion of the bone. But unfortunately, when we get down here near the joint, we can see that it's kind of moth-eaten and a bit expansile. You can see how there are some changes and some proliferation on the external surface or the cortical surface of the bone. And when we look at it from the side, you can actually see a little osteophyte there and kind of production of bone all around that area. And this x-ray is pretty classic for an osteosarcoma or a primary bone tumor. And unfortunately, large, giant breed dogs are predisposed to developing primary bone tumors. We think the reason is because they are putting lots of wear and tear on that growth plate there over their entire lifespan. And so we actually did an aspirate of McGuire's tumor at that site and got cells that were consistent with bone tumor osteoblast cells. We did chest x-rays and blood work. All of that looked good. He didn't have any evidence of tumor spread at that point in time. So when we think about what our options are for treatment for osteosarcoma, the standard of care is to remove the tumor, which in that location, the only way to remove it is to remove the limb, because you can't just take out a chunk of bone and expect for them to be able to walk on that leg. And because we know of their aggressive behavior, we also have planned, or chemotherapy is also part of the standard of care for these guys. We do know that dogs survive significantly longer if we remove their tumor and treat them with chemotherapy than if we don't do anything or if we just remove their tumor. So, unfortunately, because McGuire was 170 pounds, we were really worried about whether or not he could walk without that front leg. So there are some things we can do to try and spare that front leg. And McGuire, what we did a bone scan. So this is a nuclear medicine scan where we actually gave him a radioisotope that localizes to active bone proliferation. And you can see his tumor right here. This was actually the injection site of the radioisotope. But it looks like it's confined to this region. It's a little bit extensive. But we look at all of that site so we can make sure there's not any other areas in the bone. We also look in the lungs and the other bones to make sure we don't see area of increased activity. But McGuire ended up having what we call limb-sparing surgery, where we took out that portion of abnormal bone and we put in a prosthetic. So this is a special plate that you can order that has a metal rod in the middle of it that goes into the defect of the bone. And this out here is actually the bandage cast that was put on his leg right after surgery. But this is his post-op film. This is his elbow here, and this is his paw down on this side. And this is him the day after surgery. So he was up, and he was actually walking on his limb the day after surgery. Dr. Roush and the student are actually checking his toes to make sure they're not swollen after the fact. So he did really well. He's got an incision up here because they actually did a bone graft. They went in and took out some of his bone out of his hip bone, his non-weight-bearing bone in his hip, and put it in here to help that graft heal, that prosthetic area to heal. Then we gave him chemotherapy after the fact, and he did really well with his treatments. And this is McGuire when he was coming in for his last check with us. We still had the bandage on him just to try and protect that area. So he did well. Unfortunately, he did eventually develop tumor recurrence at his site, but he did live for about 9 months. The median survival time for dogs with osteosarcoma with amputation and chemotherapy is about 10 months, 10 to 12 months. And so he lived very close to what the median is. But I think his owner was really happy with how he did and how he felt throughout that time. And he was able to ambulate and get around like a normal dog. So with that, I made it through.
So do you have any experience working with large animals that have tumors?
Yeah.
And then getting pulled into those kind of cases?
So the question is whether or not we get to work with large animals too, and we do. Not very often, but occasionally we do. Horses with lymphoma, cows with cancer eye. We see a lot of the subcutaneous tumors in horses. We see a fair number of exotic animals as well. Ferrets get a lot of cancer. So we've consulted with zoo animals. A couple of the tigers at the zoo in Manhattan have actually died from lymphoma. So big cats can get cancer too. So yeah, lots of species we've worked with. It's hard to figure out how you treat them because to give them chemotherapy over and over again is not practical.
It's probably very expensive.
Yeah, yeah. So tigers don't really want you to put an IV catheter in.
When I was a vet student, oh, okay, so there's a question. When I was a vet student, there were weekly radiation sessions with a horse that had a tumor in its sinus. So every week we would knock down the horse, do radiation therapy, cover the horse, week after week after week.
When I first came to Kansas State, we had an alpaca that we actually treated for a tumor in his mouth with radiation therapy, fibrosarcoma. And that alpaca did really quite well. So,
all right, we have a question from Blue Valley Caps. Kelly, if you want to unmute your mic, you're welcome to answer. We see it on the chat. Is it common for a tumor to grow back in the same place like Gracie's?
And the answer is yes. If it's incompletely resected, it is common for them to recur. To some degree, it depends on the type of cancer and how biologically active, how rapidly growing those tumors are. There are some tumors that even when incompletely resected don't recur. But the majority of incompletely resected tumors will actually recur at some point. It depends on the tumor type, how quickly that is. But yes, that certainly is a concern of ours if we can't completely remove it.
Darn, didn't get it all.
And that's one of the reasons we use radiation therapy. If we know we have an incompletely resected tumor, we use radiation therapy to try and kill the residual cells in the area.
And then we had another question. Yeah. Go ahead, you do it.
No, you do it. It makes me feel like there's somebody else over there.
Yes, all right. So at the beginning, you had the percentages about cancer prevalence in dogs versus cats. Why was it so much higher for dogs?
That's a good question. Part of it might be just a matter of diagnosis. I will tell you in my practice, it's probably 80% dogs and 20% cats. But when you look at pet ownership, it's not necessarily that more dogs are owned than more cats are owned. But I think it's probably a factor in diagnosing and pursuing treatment to some degree. Certainly the highest incidence of cancer in cats is hematopoietic neoplasia. So lymphoma is the most common cancer in cats, and probably the reason for that is because of the feline leukemia virus and the association with that virus and lymphoma development. Now, the incidence has decreased in the last 10 to 15 years with the use of the feline leukemia virus vaccine, so preventing the tumor or preventing the virus or infection with the virus. But I don't think we know completely why, but I would guess it has to do with the diagnosis and presentation, recognition of it. So,
thank you very much.
You're very welcome. Thank you.
Are there other questions?
All right.
Okay.
Well, thank you all for your attention. So thanks for coming. Spending your nice afternoon here after a rainy day.